Escalation versus induction. This is complicated.
The way that we approach disease-modifying therapy is called the style of treatment. I mean style as in the way that the neurologist orders and sequences the medicines. Now, there's a very common style, which is escalation. A more appropriate way of treating a chronic neuroimmunologic condition is to use either early application of highly effective therapy or induction. And those are two other models or styles in treatment. Induction therapy is one of my favorite styles of treatment. You mentioned that you've been exposed to alemtuzumab, Lemtrada. That is a form of induction therapy. So you're trying to reboot the immune response so it's less autoreactive. And if you can induce a change in the immune response, you don't need to keep treating the human being. If we use Lemtrada as an example, you take 5 days in a row, you wait a year, you take 3 days in a row, and then you're done for the rest of your life unless you have new disease activity. And when we go out 10 years, 55% of people never get retreated because they don't have any further disease activity, which is pretty freaking cool.
Is there a point in your life with MS where induction therapy is no longer appropriate?
I think 2 years ago, I would have said yes, that induction therapy is something which is more appropriate very early on, except I don't feel that way as much anymore. I'll share with you some recent experiences I've had, actually taught to me by an outstanding MS neurologist in Canada, of using cladribine, which is like, I call this micro-induction therapy. I've actually started to use this drug in 65-year-olds, 70-year-olds, 75-year-olds, and people who are in the second half of their disease process, and they still want to be treated, but they don't want to be on something for continuous amounts of time. And so we can induce their immune system one last time, and then we hopefully will not need to continue to expose them to therapy. Generally speaking, we think about induction earlier on in the chronology of the human being's life, but I'm actually starting to question my own thoughts about that as an example I've given you.
Dr. Boster, is there anything else you want newly diagnosed patients to know about medication?
I want them to know that medication is a tool, one of many tools that we bring to bear to help you live your very best life despite having MS. I have failed 0 times in finding a therapy that someone can tolerate if they want to be on a therapy. The only patients in my practice who are not on a therapy refuse to take one. And so it's my hope that you will be open-minded, and that even though early on in the disease process, you might not recognize what might come if you're untreated successfully, please trust that with medicine, we have revolutionized the history of this disease. We have changed the course of the disease by the earliest application of the most effective therapies. And so I want that for you and your family. And I want that for you 20 years from now.
I would love to know what you think is the most promising next thing coming in MS.
So diagnostically, I am extremely excited about the evolution of neurofilament light chain in the serum. So this is a blood test which is close to prime time. It's not there yet, but it's getting really, really close. And it will be the first viable biomarker of response to DMT and disease activity. And in my mind, that is transformative. And I think that's within striking distance. I'll still have some hair up here when that comes out. Now, the second thing that I'm super excited about is on the therapeutic side. And it's the development of therapies that impact the innate immune response. And so at the Boster Center for MS, we're very actively involved in several clinical investigations studying these small molecules called bertine tyrosine kinase inhibitors, or BTK inhibitors. And it turns out in early testing, they're rock stars in treating MS. And they do some things that are novel. Number one, they turn off B cell communication without murdering B cells. Number two, they turn off activated microglia. They're these innate immune cells that we've never been able to reach. And these molecules that we're studying do not increase risk of infection substantially. You can imagine a world where you put someone on an alemtuzumab and then you put them on a BTK inhibitor as a maintenance, or you put them on an ocrelizumab and then you keep them on a BTK inhibitor in addition, or something like this, where you're trying to use multiple different mechanisms. So I'm very, very excited about what's coming.
This is all good news. Thank you so much for your passion. I think it's knowing that there are highly effective tools for people and just getting that messaging out. There's a lot to be hoped for.
Absolutely. Thank you for the opportunity to talk. I hope we get to do it again sometime soon.
Induction therapy attempts to reboot the immune system so that it's less autoreactive. If a positive change in the immune response can be induced, the need for continued treatment is reduced. Induction therapies can be used for all ages and all stages of multiple sclerosis, not only early on. For more content on MS, from treatments and diagnosis to mobility and sex, subscribe to LivedHealth MS.